OCT maybe are using them less and less, but still the fundus fluorescent angiography is a very useful tool, and some newer developments are also there. We'll just briefly talk about them, why this topic is still very important for us. So just a brief touch on history. It was this was a synthetic compound made by Adolphe von Baer in 1871, and then slowly used in animals 1882. But nearly more than a century later, that it was started using human subjects by MacLean and his colleagues. And the advent of the new photographic system, the clinical use of this drug could be made. So why sodium fluorescein? We use sodium fluorescein because it's water soluble, it's inexpensive, it's inert, it doesn't cause a lot of reaction or anything in the human body. And the fluorescence of this dye is also very suited for our blood. It is in the normal pH 7.4, and then it gives excitation emission at 2 wavelengths, and both of which are visible. So we can use this to capture this in our camera, and hence the photography can be displayed. So you probably use sodium fluorescence so commonly in the OPD also. So when you shine in a blue light, it gives you back green light as an emission, and this is then captured by the camera. So as we know, FFA is an invasive procedure, so we need to take care while doing this investigations. We need to counsel the patient what we are going to do, and because the patient also needs to cooperate with us, so we have to make sure that they understand what we want them to do during the procedure. And since it's an invasive procedure, we have to take an informed consent. There's also a history of drug allergy is also important. If the patient has any reaction earlier with this dye or any related drug, could be a caution for us. And we need a visitor also, because this is an invasive procedure, as we mentioned, talked about. And the media clarity is also important. Make sure that even if the patient requires a FFA, if the media is not clear due to corneopathy, cataract, or any other cause, then you will not get a good picture, and an entire procedure is wasted. The general status of the patient is also important, because the patient has to sit with you in the chair, positioned well in the FFA machine, and then cooperate throughout the procedure. And this is very crucial while doing FFA. And then we also need to think about possibility for cannulation, because the drug is given intravenously. So some patients may have difficulty, and we need to prepare for that also. Pregnancy is an absolute contraindication. As of now, we don't do it in pregnancy because there's no any information regarding whether this drug is safe or not. So the procedure, as you can see, the patient is fitted. We have assistant, and the technician who is now planning to is about to give the fluorescein is loading the drug. You can see here there's some emergency drugs. Mostly we have drugs like adrenaline or any antihistaminic IV drugs, because they may have any allergic reaction. And if possible, you should also keep an oxygen cylinder just in case the patient requires any ventilation. But mostly it's quite a safe drug. It has very good safety, because we have very less problems while doing FFA. Around 5% of patients, or less than 5%, might complain of mild nausea and vomiting. And I've seen this happening because patient has to cooperate for a long time. There's a pupil is dilated. We do a lot of photography with the light, so that makes the patient a bit uncomfortable. Also, it's really hard to say whether this is related to the procedure or the drug itself. Some patients, less than 1%, will have some urticaria. They have this itching instantly or around 30 minutes or so after the procedure, and few patients may even collapse. There's a rare incidence of mortality while doing an FFA. That's roughly 1 in 2 lakh patients, which is very, very rare, but you may encounter it. So that's why very important to take a consent form before you do this procedure. And as we talked earlier, we don't know about the fetal toxicity associated with the use of sodium fluorescein. So we do not do FFA in a pregnant woman. And also, it's important to observe patient after the procedure. The patient may be very fine during the procedure, but may collapse later. So we have incidents where the patient was okay after the FFA, but half an hour later, the patient had started having problems. So what you need to do, even after the procedure is over, make the patient sit down for a while, half an hour, maybe even 1 hour, and make sure they are well before you send them off. So manage the site where we talk about you need to keep the emergency drugs handy. Make sure that the drugs also are not expired, because sometimes we don't use them for a long while. And usually the drug itself doesn't cause much problem, but there may be, as we mentioned, mild side effects, but usually patients respond very well and they recover very well. But if they have any severe side effects, like they collapse or they have any cardiac problem during procedure, you need to refer to the emergency department as quickly as possible. So this is a typical fundus angiogram machine. You can have the optical system, and there's a digital camera mounted. If you have seen the older FFA machines, there was this older camera with this film reel that was used, but now there's been largely replaced by a digital system, which has been much more convenient, and the procedure has become much simpler for us. And the typical fundus film, it just gives you a 60-degree, and then the patient has to see in different gazes to take a picture of the entire retina as far as possible. Obviously, we can't go too much periphery with the typical fundus fluorescence machine that we have. But we'll talk about the newer advanced, why it's getting even better than this. So once you inject, then we have certain stages. So the timing of the is quite variable. So this is a pre-fill. That is, once you've injected, the time it takes for the drug to reach to the retinal vessels, that's around 17 to 15 seconds. If you have an older patient, they take more time. If you have a younger patient, the dye reaches the eye much quicker. Once it reaches the eye, then it's first, as you know, with the anatomy of the eye, it starts with the choroid, and around 1 to 3 seconds, it starts with the arteries. Then the slightly longer phase, that's the arteriovenous phase, which we'll see in the pictures, is early, mid, and late phase. Then this entire procedure will complete around roughly 30 seconds. Then you have the recirculation phase, and what the recirculation phase is, the drug keeps on recirculating.
Excuse me, Pratap, sir.
Yes, sir. Yes.
Excuse me, sir. Sir, I guess we are going so fast. Can we be a little bit slow, sir?
Okay. So in the recirculation phase, what happens is the drug is recirculating in the body, and then slowly the drug is excreted. So we have the less and less of the dye. And so, as you see, the sodium fluorescein, the fluorescein in the picture will be less intense. And then we have the late phase, which is described around 5 to 10 minutes, when most of the dye is slowly eliminated from the system, and you have the dye remaining in a few places only, which we will see in the picture. So you just see the picture. This is when maybe some choroidal fluorescence was not very clear, but you can see in the next picture, you have slowly choroidal fluorescence seen, and this is when the dye has reached the choroidal circulation. Very shortly, then you have the first, it also starts in the artery. From then on, what we talked about was the arteriovenous phase. You can see the artery is quite well illuminated, but in the vein, you can see there's a laminar flow. That is, the dye is only coated in the periphery of the veins, not in the center part. Slowly, when we start in the mid phase, you can see again the arteries, the fluorescein is less, but in the vein it's getting much more brighter, and now you can see the entire vein is filled with the dye. And in the late arteriovenous phase, as you can see in the picture, the arteries doesn't have much fluorescein, but in the vein it shows quite bright. And then what we talked about is the recirculation phase. The dye keeps on recirculating as it gets less and less. So in the late phase, you can see both in the arteries and the veins, the sodium fluorescence is much less. You'll see some areas where there is staining, like typically can be seen normally, as you can see in the margin of the optic disc. So this is quite a short procedure. If you see the main phases, that is, we talked about from the earlier to the arteriovenous phase, that we talked about roughly 30 seconds. So once the sodium fluorescence starts circulating into the eye, you need to take pictures as quickly as possible with our conventional fundus fluorescent angiogram. So we need to listen to them for. So the technician who is doing the FFA needs to know what we are doing for, what is the indication, and what part of the retina is very important. You can't take images of the entire retina, because you can't. The fundus camera only gives you a 60-degree access. So you need to ask the patient to see in different gazes, and obviously we need to see the other eye, both eyes. So the time management is very crucial. So before you sit down to do a fundus fluorescent angiogram, or you are ordering a fundus fluorescent angiogram, you can actually talk to your technician to say what part of the retina you want, or what part of the eye you want to take a fluorescent angiogram of, which eye you have more preference for, so that the FFA technician will take more pictures and of that area, so that we have better pictures of this area, and then he can prioritize in the other areas as well. So as we talked about normal fluorescein, it starts from the choroid. Roughly in 1/3 of the patients, they will have the pseudoretinal vessels, which is a separate vessel supplying to the macula. And then of the optic disc, we saw in the late phase, there is the pooling of the dye in the periphery, in the margin. Then obviously the retinal vessels, the macula, and the sclera. But what we're interested in is to find out the pathological fluorescence. And there are two types of pathological fluorescence. We see the hyperfluorescence and hypofluorescence. So very easy terms. Hyperfluorescence, obviously, when you have more of the dye being seen in the picture, and hyperfluorescence when the less of the dye is seen in the picture. So the four things we see in the hyperfluorescence are window defect, leakage, pooling, and staining. So when you're analyzing fundus fluorescence angiogram picture, you have to, what we need to see when we are analyzing hyperfluorescence is to see when the hyperfluorescence is starting, how it's ending, what about the margin, is it sharply defined, or is it very dull or very illy demarcated. So for instance, in the window defect, it's a very sharply defined hyperfluorescence, but it comes in the very early phase. That's right from the choroidal stage of the circulation. and it rapidly disappears in the later part of the arterial or late arteriovenous phase, and definitely not in the late phases. So window defect you have to catch much earlier, and so if you see a well demarcated area of hyperfluorescence which is well demarcated, comes very early and disappears quite quickly, then what you are probably seeing is a window defect. And as you know, as you've probably read, window defect is when there's a there's defect in the RPE, so that the sodium fluorescein is seen much through the choroidal circulation. The leakage and pooling will start a bit later. In the leakage, the margin is very fuzzy, so if you see leakage in the early phase, you may see a well demarcated area, but in the late phases, then it becomes very fuzzy. The pooling will start slightly later than the leakage, but it starts from a well demarcated area. The hyperfluorescence increases as you go on in the late phases, but it doesn't exceed the area it is staining. And the staining is the last thing you see, and this is actually in like a old this retinal scar or something. The dye takes some time to get into this, so the staining you will see hyperfluorescence in very late phases. So, and based on how the margin behaves and when the hyperfluorescence starts, it gives you a good clue in defining what the type of hyperfluorescence you've seen. The other what we see is called hypofluorescence, and there are two types. It's a blocked fluorescence. Block means something is blocking the normal fluorescence that is over there. Maybe the block is in the vitreous, or maybe in the retina, or maybe a dark, if it's blocking the choroidal fluorescence, it could be a pigmented lesion in the RP also. While analyzing a block fluorescence, make sure that you see the fundus of the picture of the patient also while analyzing, because it helps you define what type of block fluorescence it is. And the other is obviously the vascular filling defect, and what it really means is the blood flow is blocked, and hence our sodium fluorescein that is flowing through the blood is not able to reach that area. So a few conditions while you are, as we talked about the media, so, and also other factors. So to take a good picture, you need a well dilated pupil. You also need to have a very clear media. So this I can show you. This is a FFA of a patient who has an undilating pupil, and as you can see, we have a very poor fundus pictures. So we need to, before we order FFA, you need to make sure whether we have the patient is suitable for this study, for this investigation or not. Next is the hazy media. This is a patient who we did FFA, and this patient has some cataract, and as you can see, we hardly can see anything. So ordering FFA in this patient will not be very helpful for us. So let's do the interpretation parts. Some common retinal conditions we encounter. So one is proliferative diabetic retinopathy. As you can see in this, you can see areas of hyperfluorescence, and this is due to formation of new blood vessels. There's NVD, there's multiple areas of NVD. Some dark areas you'll be seeing is actually the laser scar marks. And as we talked earlier, that the hyperfluorescence starts much earlier, and in the late phases, you can't define the margins. So this is area of hyperfluorescence. This, what we talked earlier, is area of the blocked fluorescence. And in this case, the large bleeding in the preretinal area, probably the subhilar area, is causing a blocked fluorescence. Because of that, you can't see posteriorly. Similarly, many indications for in FFA in diabetics, and one important is to see the condition of the macula. Many times you may encounter a patient where the fundus doesn't look like that bad, but you do not know why the patient is losing a vision. So a patient like that obviously has some diabetic edema, but when you do an FFA, you know far more. You can also see there is actually capillary dropout areas. The foveal avascular zone is enlarged. There's capillary dropout areas, and you can see large area of capillary dropout areas where there is no vascular flow, and that is why the dye has not reached there. So macular ischemia actually is a very strong indication for doing FFA in a diabetic patient. So if you have a patient where, especially where you see the fundus and do not know why precisely the patient is losing a vision, just doing an FFA will tell you that whether the patient has macular ischemia or not. As you know, ischemia is something we cannot diagnose clinically, and FFA is the only tool that will help us to diagnose an ischemia. This patient also has new vessels, as you can see in the periphery around the arcade. And the other part is definitely in part of diabetic maculopathy is diabetic macular edema. This patient, as you can see, there's a dense hubs in the center, and in the late phase, you can see there's leakage all around. So the use of FFA is also for the treatment part of also in these kind of patients. If you look at the FFA, it can tell you which area of the retina is leaking, and you can actually plan your laser treatment also on basis of that. So some other indications like a branch vein occlusion in this patient. This was a patient of non-ischemic BRVO. You can see in the fundus photo as we talk, there's a lot of hemorrhages, and because of this, there's some blocked fluorescence over there, but we don't see much of capillary dropout areas. This another patient is also a case of BRVO, but this patient has ischemic BRVO. You can see the fundus of the patient, lots of hemorrhages, some area of hard exudates. When given FFA, then you will see large area of capillary dropout. So this capillary dropout area is actually what we can only analyze it with the FFA, as we talked earlier. So the prognosis based on whether the patient has a non-ischemic BRVO and a ischemic BRVO actually helps differentiate the prognosis of the patient, how we manage this patient, whether this patient requires laser or not, and overall prognosis of the disease. So definitely with ischemic BRVO, the patient will have a worse prognosis, and in the long term, the patient may have developed new blood vessel formation leading to fraction, vitreous hemorrhage in future. Likewise, in central vein occlusion, this patient has ischemic central vein occlusion. There are a lot of capillary dropout areas seen, and also areas of blocked fluorescence due to hemorrhage. So normally when you have a patient of venous occlusion, we don't start doing FFA right at the start the patient comes to you, especially if the patient coming to you earlier. Usually we are waiting after 3 or 4 months. A lot of this hemorrhage will subside, and doing FFA is more worthwhile because they will tell us much more like how the capillary dropout areas are. If the patient has a lot of hemorrhage in the fundus and you order FFA, then all the blocked fluorescence will obliterate all the useful findings like the capillary dropout areas for us. So if you want to plan a venous occlusion patient, make sure the patient has the venous occlusion around roughly 3 to 4 months, or there are not too many hemorrhages that will obscure your findings. This is another patient, an old CRVO patient with macular edema. So as you can see, the hemorrhages are subsiding, and there's some, and what you can see is a typical cystoid macular edema, the petroloid pattern that you can see in the FFA in the late phase. Another indication is age-related macular degeneration, and you can see 2 stages in this patient. The first stage is when you can see hemorrhages, and when you do an FFA in the center, you can see a nice lacy pattern, and this is the early stage of a classical CNV. That is the type 2 CNV, where the new blood vessel from the choroid is actually in the retinal surface. Whereas this is a late phase of, in the late stage of the, the patient has now a large deciform scar, and as you can see in this patient, you can see a staining at the late phase. Then the dense tissue will actually absorb the dye in the late phase, and when you see in the late phase, you will see a dense, the staining at the edges of this dense scar. Another indication you've probably seen is the CSR. You can see 2 kinds of patterns. So CSR, there is actually pooling of the dye in the subretinal space. As you can see, a well-demarcated area is there where the dye is pooling. As you go in the later forms of phase, the area actually becomes more hyperfluorescent because more and more dye will pool in this area. And see likewise in this area also you can see a well-demarcated area pooling, and it shows 2 patterns. One is the smokestack pattern, as if there's smoke or fire is there and the smoke is going up, which means a typical pattern when it starts, goes up, and then it slowly spreads around. The other pattern we see actually like more commonly than the smokestack appearance is the ink blot pattern, and this is typical like it's ink. You put ink in a paper, it slowly spreads. So it starts like a small blot, and then it slowly spreads. So this is info. So FFA in a CSR, as you know, is important for us diagnosing and also for treatment. When you have a CSR, if you do an FFA, the laser treatment, the focal laser treatment actually is based on where the leakage is. So if the leakage is in the center of the fovea, then we cannot treat with laser. That is the foveal avascular zone. But if it's anywhere else, then we can treat a laser. So likewise, in this patient, if the fluorescent leakage started at this area, you can give a couple of spots with laser in this area. Likewise, in this patient also, you can see an ink block pattern. So wherever the leakage is, you find that area with the help of FFA, and you can give focal laser in these patients. So in conclusion, the FFA is an invaluable tool for us in understanding the treatment of the ocular diseases. But then we should remember that to have a good FFA result or the good use of the FFA, you need a cooperative patient. So a very sick patient or a patient who's not able to understand and cooperate, it's not a very good test. You need a good fundus camera, a person with expertise in photography, and you also need to do a correct interpretation of the results. But then what is new? As you know, in my day-to-day practice also, now I'm doing FFA much less and less because of many new advances, especially with the use of OCT. But still, there's some sectors in FFA is now slowly coming up, although are not accessible in all places, which are exciting. One is ultra-widefield angiography. As we saw, the fundus camera doesn't give us a very wide picture. Like this is, you can see a typical fundus, conventional fundus fluid angiogram of the patient, but with this ultra-widefield angiography, you can capture a much larger area. And the use of this investigation has now taught us many new things. So earlier we would see a new vessel in the central area, then we were only lasering around the equator, but now we are going beyond that when we see, and the ultrawide field angiography is capturing the capillary droplet areas in much peripheral that was otherwise not possible with the fundus angiogram. As you can see in this patient, there is some area of capillary droplet in the center, but if you see the periphery, there are large area of capillary droplet areas. So if I were to treat that patient, I would have to make sure that I would laser all these areas of capillary droplet areas. So only with the wide field angiogram can you capture these areas, and definitely a lot of part of the diagnosis that was missing, which we didn't have with the conventional FFA, is now coming up with this ultrawide field angiography. So this is what is used, Optomap. This is by the other company Optos, and gives a very wide field image, not only for FFA, but also you can take a picture of the fundus with this. And you can do this without undilated pupil. So this is quite exciting for us with the Optos, or like Heidelberg has its own systems likewise to use. Similarly, for children, we can use a RedCam, which is a portable device, a handheld portable camera, which is attached to this big machine over here, and then it can be used to take a fundus, large field fundus photo, as well as the angiogram of the child. So this we typically use in patient of ROP, that is premature babies with retinopathy of prematurity. And this is a nicely done FFA of a premature baby. You can see this is till the area where the vessels have grown, and this is the avascular area. There's no growth in this area. But with this advantage, with the ultrawide field angiography will give you a very wide view up to 200 degrees. And then what we talked about earlier, with the conventional photography, you need to ask the patient to see in different phases, to different areas, to capture different areas. But with the ultrawide field angiography, you can just take a single picture to cover a large area at a single go. So you don't need to have the patient to see in different areas. Also, you don't lose so many areas that you would otherwise miss if you're doing a conventional FFA. And definitely the patient is will have less photophobia, is more comfortable, because these devices use a different form. They use actually laser to capture the image. And so this is a new evolving frontier which is very exciting. But the disadvantage why this device which is so useful, is not present in very few centers around the world. It's very, very expensive, and still, although it captures a large area, there are a few areas like towards the very periphery of the aura that is not captured. So with the retinal examination, you still need to go into the periphery of the indentation if you want this area, but still it definitely in comparison to the conventional FFA, it will give you a much better image. The other, you probably already heard, with OCT angiogram. This is actually uses the movement of red blood cells in the blood vessel, and based on this, the computer actually makes an image of the capillaries. But OCT angiogram only gives the image as of now only of the posterior pole. We don't have a periphery or even a wide field image with this. However, the good part of OCT angiogram, as you all know, it uses light, so it's less invasive. It has no non-invasive procedure for us, much safer. So you can repeat this very much. So you can see in this patient, it shows the different levels of the capillary scene, the superficial, deeper layers. This is where the photoreceptors are, and the choroidal vessels. So the OCT angiogram is very exciting for us when we're slightly treating patient with wet AMD, because with FFA you can't keep on doing multiple angiograms because it's invasive procedure. But OCT angio, you can see the image much better than actually with the conventional FFA, and then you can repeat this procedure to see how the patient is doing. So advantage of OCT is a non-invasive procedure, shows much detail in the deeper layers as we talked about. But the disadvantage, there are certain artifacts, and only gives a very limited image of the posterior pole only, and certain details like pooling, leakage, staining that we see in the conventional FFA is not seen with this OCT angio. So in conclusion, FFA continues to be a very important device for us. And although with OCT now we are taking many indications that we were using FFA earlier, but still, and also with the newer trends that's opening up much more possibility for us in future. So definitely, I think it's quite exciting for us, and definitely FFA in days to come will probably still be a very important device for us for diagnosing and treating our patients. Thank you.
Thank you so much, sir. Such a wonderful presentation. So we are heading towards the discussion session. If anybody have the question, please pop on the chat box, or you can mute yourself and proceed with the question.
हेलो नमस्ते सर म अमित कुमार सिंह मेची हाई हस्पिटलबाट हेलो
भन्नु न
म सर अब सीएससीआर मा जुन पुलिङ र पुलिङको भन्नुभयो नि सर अब सीएससीआर मा त लिकेज टाइपको पेटर्न पनि देखिन्छ हैन हाइपरफ्लोरेसेन्स देखिन्छ अनि त्यसपछि त्यो साइज र इन्टेन्सिटी विथ द टाइम दुटै चेन्ज हुँदै गर्छ सर त्यो एक्ज्याक्टली सर त्यो दैट इज पुलिङ और लिकेज सर
हैन यो चाहिँ पुलिङ हो सीएसआरमा चाहिँ जुन छ पुलिङ भने चाहिँ के हो भने इट्स पर्टिकुलर एउटा एनाटोमिक एरियामा चाहिँ डाई जहाँबाट लिकेज पोइन्ट छ त्यहाँबाट चाहिँ निस्केर चाहिँ त्यहाँ जम्मा भएर बस्छ लिकेज त भइरहेछ तर यसमा जुन लिकेज छ यो चाहिँ आरपी को लेभलमा छ जस्तो तपाईँ हामीले न्यू भेसल हामी डायबिटिजमा जुन देख्छौँ न्यू भेसल फर्मेसन त्यहाँबाट चाहिँ डाइरेक्टली चाहिँ तपाईँको रेटिना अथवा इभन भिट्रस क्याभिटीमा लिकेज देखिन्छ भने यसमा चाहिँ लिकेज चाहिँ पोइन्ट आरपीबाट छ त्यहाँबाट लिकेज भइरहेछ र त्यो चाहिँ किनभने सीएसआरमा तपाईँले देख्नुभयो होला डिट्याच रेटिना चाहिँ जुन सिरियस डिट्याचन भएको एरिया छ त्यहाँ डिट्याच भएको हुन्छ र त्यहाँबाट लिक भएर चाहिँ त्यो डाई चाहिँ त्यो ठाउँमा जम्मा हुँदै जान्छ जुन हामीले देख्यौँ पिक्चरमा इन्क्लक प्याटर्न देख्यौँ हामीले स्मोक स्ट्याक प्याटर्न छ र यसको इम्पोर्टेन्स हामीले जुन कुरा गर्यौँ खालि लिकेज पत्ता लगाउन मात्र होइन कुन एरियामा लिकेज छ र त्यहाँ हामीले फोकल लेजर दिन सक्छौँ सक्दैन हामीले त्यसको चाहिँ युज गर्न सक्छौँ
थ्याङ्क यू सर र अर्को एउटा सर जुन जुन ल्यामिनार फ्लो भन्नुभयो नि सर त्यो चाहिँ अर्ली भेनस फेजमा देखिन्छ कि त्यो आर्ट्रियो भेनस फेजमा देखिन्छ
अनि आर्टियो भेनसकै अर्ली भेनस अब डेफिनेटली आर्टियोबाट पहिला भेनमा तपाईँको जुन हाम्रो ब्लड फ्लोको नर्मल एनाटोमिकल प्याटर्न छ त्यसमै जाने हो र सुरुमा चाहिँ थोरै डाई मात्र गइरहेको हुन्छ त्यही भएर त्यो चाहिँ भेसलको साइडमा चाहिँ कोट भएको देखिन्छ र गझै जसरी आर्टियो भेनस फेज चाहिँ तपाईँको बढ्दै जान्छ त्यो भने मोर एन्ड मोर डाई चाहिँ आर्टियोबाट भेनतिर गइरहेछ त्यसपछि मोर तपाईँले सेन्ट्रल पार्ट अफ भेनमा पनि देख्नुहुन्छ प्लस हाइपरफ्लोरेसेन्सको जुन इन्टेन्सिटी छ त्यो पनि चेन्ज हुँदै जान्छ आर्टियोमा चाहिँ अलिकति फेन्ट हुँदै जान्छ भने भेनमा चाहिँ अझै ब्राइट हुँदै जान्छ
भनेपछि त्यो लैमिनर फ्लो इज सीन इन आर्टरी भेनस फेज और अर्ली भेनस
यो चाहिँ हैन यो अलमोस्ट यो कन्टिन्युअस प्रोसिजर हो तपाईँ ठ्याक्क जस्तो आर्टी फेज एन्ड हुन साथ भेनस प्रोसेस स्टार्ट हुने हैन आर्टी भेनस फेज चाहिँ एउटा कन्टिन्युअस प्रोसेसै हो तपाईँ ग्रेजुअली त्यो डाई चाहिँ तपाईँको जुन नर्मली आर्ट्रियलबाट चाहिँ क्याप्टराइज हुँदै गई भेन्युल्सबाट भेनमा जाँदै जान्छ त्यही भएर चाहिँ यो चाहिँ अलमोस्ट भन्नु कन्टिन्युअस भनौँ न एउटा फेजबाट अर्को फेजमा एज अ होल कन्टिन्युअसली स्विच भइरहेको छ त्यही जस्ट एउटा आर्ट्री फेज स्टप हुन साथ भेनस फेज स्टार्ट हुने हैन त्यो सँगै भइरहेको छ ग्रेजुअली आर्ट्री एम्प्टी हुँदै गइरहेछ तपाईँको भेनमा चाहिँ डाई बढी आउँदै जान्छ
हजुर थ्याङ्क यू सर
मैले एक दुईवटा अरू क्वेसन पनि देखेँ बसन्त पौडेलले चाहिँ डिफ्रेन्ट च्याट बक्समा चाहिँ डिफ्रेन्स बिट्विन एफएफए एन्ड एन्जिओसिटी डेफिनेटली यसमा चाहिँ एन्जिओसिटी र यो चाहिँ डिफ्रेन्ट मेथड भइहाल्यो एफएफएमा हामीले जुन देख्यौँ हामीले फ्लोरेसेन्ट डाई युज गरिरहेको छौँ त्यसपछि डिफ्रेन्ट एउटा स्पेसल फन्डस क्यामेराबाट फोटो लिइरहेको छौँ यो इन्भेजिभ प्रोसिजर भयो यसको चाहिँ मेकानिजम डिफ्रेन्ट छ भने एन्जिओसिटीमा चाहिँ हामीले जस्ट लाइटबाट यो काम गरिरहेको छौँ स्पेसली जुन ओसिटीमा युज हुने लाइटबाट चाहिँ जुन चाहिँ ब्लड भेसलहरूको जुन रेड ब्लड सेलको जुन मुभमेन्ट चाहिँ भेसल्सहरूमा त्यसबाट चाहिँ उसले इमेज बनाइरहेको हुन्छ र एन्जिओसिटी डेफिनेटली डिफ्रेन्ट छ किनभने यो चाहिँ नन इन्भेजिभ प्रोसिजर भयो र डेफिनेटली फ्युचरमा चाहिँ एन्जिओसिटी क्वाइट चाहिँ प्रोमिसिङ छ र अहिले एन्जिओसिटीको एउटा ड्रब्याक चाहिँ के छ भने एउटा लिमिटेड एरियामा त हामीले पोस्टेरियर पोललाई मात्र यसबाट चाहिँ भिजुलाइज गर्न सक्छौँ त्यही भएर एफएफएले चाहिँ त्यो हाम्रो वाइडर एरिया दिन्छ र सर्टेन पुलिङ जस्तो लिकेजहरू सर्टेन कुरा छ तपाईँलाई एन्जिओसिटी दिन सक्दैन त्यही भएर डेफिनेटली एन्जिओसिटी लेस इन्भेजिभ छ देयर इज नो इन्भेजिभ प्रोसिजर त्यही भएर चाहिँ हामीलाई चाहिँ युजफुल छ र डेफिनेटली यो चाहिँ फ्युचरमा चाहिँ मोर एन्ड मोर इम्पोर्टेन्ट हुँदै आउँछ अर्को चाहिँ फ्रम महेश्वरी राङ्गथान क्यान यू एक्सप्लेन बिट्विन एक्साइटर फिल्टर देयर एज यू टक्ड अबाउट हामीले चाहिँ वी आर युजिङ अ ब्लू लाइट एन्ड देन वी आर गेटिङ अ green light from the emission. So we use a blue filter in the camera so that the blue light enters the eye, and then the green light that's emitted by the sodium fluorescein is then a barrier green filter is put so that now the green light that is emitted from the sodium fluorescein is actually captured to make the image. Arko चाहिँ अजितले you can add about section. Yes, definitely. Ajit, what has Ajit Thakur has mentioned, he has actually a lot of experience with OCT angio as he's using. Yes, actually, it's getting much more. It's giving us OCT angio time. It's giving us now not only in the posterior pole. Actually, it's now giving a much wider image. So definitely, it will give us more image. And also, what you mentioned is right. With the swept source OCT, actually, you can go much better in the choroidal circulation to capture much more images, which is not always possible with the conventional FFA. अर्को चाहिँ अनन्ता पौडेलले भन्नुभएको छ difference between FFA and ICGA. So ICGA is a different type of dye. It's actually made of iodine. And the difference between FFA and ICGA, if you've read, is FFA is more loosely bound. So around 80% is bound with the protein. The remaining actually leaks out. So this is very important when you are studying the choroidal circulation, because the choroidal capillaries actually is much more fenestrated, whereas the retinal vessels are not. So the study of these the choroidal circulation with FFA is limited because of that. The ICGA actually has a much more protein bound. It's around 93%. So much of the dye actually stays within the choroidal vessel and then gives you the leakage points in the choroidal vessels or not. And also the ICGA, the Fundus Camera actually uses much more longer wavelength, so that much deeper circulation of the choroid is captured.
Okay, sir, I come back. I'm suffering with the bad internet, sir. So I guess we have answered the many of the queries. So if anybody have the queries, please unmute yourself and we can come with the question. Okay. Thank you so much, sir. I guess we have answered the many of the queries, and yes. So we are very sorry for that. We have technical issues today, a lot of technical issues. And okay, so there is one question from the Maheshwari. So difference between the pseudo fluorescence and autofluorescence.
Yes, certain structures in the retina, like especially like drusense, will give you a pseudofluorescence. That is, it will actually without the sodium fluorescent dye being there, it should absorb and emit the light. That's why a red-free picture is actually important, because that will give you whether the patient has pseudofluorescence or not. But now we are using autofluorescence also for actually diagnostic devices also. That is also being used.
Okay. Okay. Good afternoon, sir. Yes, sir. You can see the question. Yes.
Yes. Okay. FFA doesn't actually change any, because the dye, as we talked, is inert. It doesn't actually change anything for the systemic circulation. So I've not encountered anything regarding any change during IOP after doing an FFA.
Okay. Okay. I guess we have answered many of the queries. Okay. Well, I guess we have answered many of the queries, and considering the time limits, here I announce the closure of discussion session. Before ending the today's session, I'd like to again express my sincere gratitude towards the Dr. Pratap sir and all the attendees, and also I'd like to appreciate all the helping hands for the ITUX program. Herewith, I am ending the today's session, requesting you all for please drop review and feedback. And so if you have any good notes before ending the today's session, to convey all the optometrists and regarding the fluorescence or about should have to take care things that before doing the FFA or anything, good notes before ending the session, sir.
Okay, thank you, Kapil. I'm actually thankful for providing this opportunity, this platform to discuss with you a few things. Actually, we definitely work as a team in the hospital, and FFA, as we know, is very important for us to do. Definitely, it's a invasive procedure, so we need to find out what kind of patient we need to see, indications, and whether the patient is fit for doing FFA or not. And on the basis of this, because it's invasive procedure, we need to be careful while doing this. But definitely, it's not, as you probably read, it's not always a very unsafe procedure. So definitely, it's a very useful procedure when indicated, needs to be done despite the invasiveness of the procedure, because it gives us very valuable information for the treatment of the patient, and still continues to be a very invaluable tool for us. Thank you, Gautam.
Thank you so much, sir. Have a good day, sir.
Okay, thank you.